This morning's session is called Medicalizing Citizens, the Harms of Screening, Disease Thresholds, Industry Influences, and the Role of Media. So that's a lot of stuff. I'm the moderator. My name is Stephen Woloshin. I'm from Dartmouth, and I'm the founder of the Lisa Schwartz Foundation for Truth in Medicine. Here are my disclosures. I received some travel support from University of Oxford, one of the meeting partners. I have grants from two nonprofit foundations, the Arnold Foundation and the National Institute for Healthcare Management. To do the grants are about helping journalists learn how to do a better job reporting on medical research. And I received an honorarium for doing one of those workshops recently for Stat News in Boston. I also have received consulting fees as an expert witness against Big Pharma for deceptive marketing. And I'm on the editorial board of JAMA Internal Medicine and Cochrane Library, and I'm a founding member of the Preventing Overdiagnosis Board. And none of these conflicts, I think, are relevant to today. Today, at the end of this session, if we do this right, you will recognize possible benefits and harms of medical screening tests and expanded disease definitions, appreciate how industry influences can promote tests or changes in disease definitions that can result in overdiagnosis or other harms, and more critically approach the news media stories about tests, expanded disease definitions. So see through one-sided coverage, look for conflicts of interest, and be sensitized to the problem of overdiagnosis. We have an amazing panel. There are 3 speakers. They'll each talk for about 20 minutes. And then there'll be time for a question and answer from people in the audience, but also people who are watching remotely. And I'll introduce each of the speakers in turn. And in the spirit of this meeting, which is all about challenging convention, the order of speakers is different than the order that appears on the screen. So we're going to start with Dr. Shelley Huang, and I will introduce her now. She's a professor of surgical oncology. She's the vice chair of research for the Duke Department of Surgery and the disease group lead for breast oncology at the Duke Cancer Center. Her research focuses on breast cancer prevention, identifying less invasive treatments for early stage breast cancer and ductal carcinoma in situ, and understanding the determinants of cancer progression. And among many other things, she's the co-chair of the National Cancer Institute Breast Cancer Steering Committee and PI of one of the 5 Moonshot Tumor Atlas Network groups. And as well, she's the co-PI of the CRUK Grand Challenge Precision Team. So thank you, Shelley, and take it away.
I might need a little bit of help pulling up the slides. Oh, was that it? I think I just down here.
Oh, why is Gail showing?
I think I probably pulled it down. All right, well, while we're getting the slides up, I just wanted to thank Stephen and the organizing committee. It's really a thrill being here, and I know we weren't supposed to talk so much about this, but I remember the first inaugural conference, Preventing Overdiagnosis conference I went to in Dartmouth, and I just felt like I had found my people. It was just an amazing experience, and I'm so thrilled to be here today. So these are my disclosures. I was funded for lodging and travel to come to this meeting by Preventing Overdiagnosis. I have several grants. These are federal grants as well as some private philanthropy funding from BCRF. I've been on the Merck Speakers Bureau. Last time was about a year or 2 ago, talking about early stage breast cancer. And I've also done some consulting for AstraZeneca as well. I helped to found a couple of companies looking at decision support and the use of big data in clinetic and Higgs boson. I don't think any of those will directly affect my presentation today. So, I'd like to start off with just the voice of the patient, because I think that is a voice that's been a little bit silent in this conference. So if you'll indulge me, there's a short video I'd like to show.
So in April of 2014, I was diagnosed with DCIS. When they gave me the diagnosis, I initially felt a lot of dread, got sick to my stomach, and just thought, oh no, so what is this going to lead to? My daughter's initial reaction was, Mom, if it was me, I'd take it out. And that was initially how she felt until we discussed it, and when we talked about the risks of surgery and radiation treatments and some of the things that can happen with that, and the fact that these are precancerous cells that may just sit there and never do anything, she came around. The initial fear that you have, I think, is just because you don't know what's going to happen.
Right, so I showed that video because I think it just centers us to what the patient experience is like when they're facing a diagnosis of DCIS, which will be the subject of what I'll talk about in the next 20 minutes. So I want to focus on 4 major topics. One is how screening has impacted the diagnosis of DCIS. Then we'll move on to what is the outcome of patients who get diagnosed with this disease. Talk a little bit about what I and others have been doing to create a path forward to potentially reduce overtreatment, and then I'll close with what the role of the media is in shaping patient perceptions about the disease. So you've seen this in similar figures during this meeting, and I just want to re-center everyone on the problem here, which is that we have many different tumor types, heterogeneity in outcomes, but as we're going further and further earlier in time with screening, we're pushing this back to a point where it's very difficult to discriminate the different trajectories of cancer progression. And so with DCIS, we're at the very beginning stages of being at a detectable phase, but I would say with blood-based biomarkers looking for pan-cancer, I think we're even pushing this further to the point where I think we're just continuing to create more confusion and more fire than light, I would say. So what is DCIS? It stands for ductal carcinoma in situ, or precancer, or pre-invasive cancer. About 60,000 new cases are diagnosed annually in the United States, usually diagnosed in a completely asymptomatic patient purely on the basis of calcifications on screening mammography. And it now is a considerable diagnosis and comprises about 20% of all mammographically detected breast cancers. Now, many people, including some in this room, have helped to inform my thinking about DCIS. And I think what we know now is that DCIS is a non-obligate precursor. So it may in some cases be a precursor of invasive cancer, but the rate and the likelihood of progression to invasive disease still remain areas where there's a knowledge gap. So let's talk first about how screening has impacted the diagnosis of DCIS, and there's no question that the impact has been profound. So 65 million women in the United States are screened annually at an expenditure of about $13 billion in annual healthcare costs. And this is what it's resulted in. In the 1980s, when you look at the top curve with the open circles, you can see that there was hardly any DCIS diagnosed. It was a very rare diagnosis in the 1980s. But if you look at the black dots, which shows the number of mammogram machines in the United States, you can see that the number of DCIS cases exactly parallels the number of mammogram machines. So I think it's safe to say that we never set out trying to find more DCIS, but it ended up being an unintended consequence of increased breast cancer screening. We recently published a paper which tried to estimate, as others have, what the extent of overdiagnosis is on the basis of mammographic screening, and we have estimated, based on this analysis, that probably somewhere around 1 in 7 mammographically detected findings is probably leading to overdiagnosis, so not a trivial number. So once patients are diagnosed, what happens to them? Well, this is data that we pulled from a national cancer database, and you can see that they almost all undergo some sort of surgery. 98% of women diagnosed with DCIS in the United States have surgery. And I will just bring your attention to the unilateral mastectomy line, if you can see my cursor there. So a fair number of women are getting mastectomies, although it's nice to see that effect has declined over time. But I would also draw your attention to the dotted line right here, which is the bilateral mastectomy rate. And for women with newly diagnosed DCIS, there are certainly a growing number of women who choose to have bilateral mastectomy for this purported precursor of cancer. So if we look at what's happening now, about 30% of DCIS patients undergo either unilateral or bilateral mastectomy, and about 50% of these patients receive radiation. All well and good if it's something that we're doing to save lives, but when we look at overall survival, it looks like patients who get more treatment might do a little bit better, but it actually is only because of patient selection for these different treatments. Because if you look at breast cancer survival, there really appears to be absolutely no impact on breast cancer specific survival, no matter how you treat the patient. So there was a really nice study that came out in 2015 which started to challenge the dogma of operating on patients with DCIS. They all did so well. Is there a group of patients who may not benefit? And I think there was a signal that probably there was. And this was, again, a retrospective registry study. And the solid line represents women who underwent surgery for DCIS. The dotted line are those who did not have surgery. And certainly for the lower grade, less aggressive tumors, there appeared to be no difference if patients had surveillance or went directly to surgery. We've done a little bit more digging into this, and we have identified a group of very low-risk patients, and the blue line here represents the risk of developing ipsilateral breast cancer, and the yellow line, contralateral invasive cancer, and that was just so we could make sure that
Dr. Francis.
I'm sorry?
Oh.
Okay. Not sure what that's about, but in any case, if we look at patients who had surgery on the left side and those who did it on the right side, I mean, the risk of invasive progression in patients, even in the absence of surgery, was quite low. So if you look at this on a systems-wide level, the usual care, you can see how many lumpectomies, radiation, all that. And when you look at what we gain from that compared to no surgery, there's a very small potential 10-year disease-specific mortality benefit. So it's not zero, but it's very small. So I'd like to just spend the next few minutes talking about what the path forward is to reduce treatment. So we've created this problem from screening. Is there a way to kind of dial it back? And you can't put the genie back in the bottle, but there are some tractable advances that we're making to try to reduce overtreatment. And that comes in the form of gathering more evidence. Because I think a cornerstone of how we move things forward is to try to create more evidence, not only for us on the provider level, but that we can convey to patients. So there are now 4 international active surveillance studies for low-risk DCIS. The primary outcome is to look at ipsilateral invasive cancer-free survival. It's usually, the comparison group is usual care, so surgery compared to active surveillance. All women continue to undergo mammography because after all, that's the way it was diagnosed. So we look for changes on mammography as a readout. And the idea is to only intervene if patients progress to invasive cancer, and then to really understand whether it makes any difference whether you diagnose and treat patients at the DCIS stage or whether early detection of invasive cancer might be sufficient to maintain the good outcomes that patients can have. This is our trial in the US called the COMET study. The trial schema is very straightforward. We take patients with non-high-grade DCIS and we randomize them to either guideline concordant care, where almost everyone gets surgery, or active surveillance, where we have them come for mammograms regularly. And very importantly, we're collecting a lot of correlative samples, both in terms of images, blood. We would love to find a blood-based biomarker for progression, and a lot of biospecimens. You know, in parallel with this, we've also started some work on understanding the molecular basis of invasive cancer progression, again, in the spirit of trying to collect more evidence to support our suspicion that there could be a very low-risk lesion that may not ever progress to invasive cancer. So, usual heat map of some of the work that we've done. And we've been able to look at patients who did and did not progress to invasive cancer, and we believe we have a potentially clinically relevant prediction, a genetic gene classifier, which may be able to predict invasive cancer. So these are the kinds of tests that we can feed directly into the patients who participated in the COMET study. So in closing, I'll just say a few words about what the role of media is. So needless to say, I don't need to tell anyone in this audience about this, which is that women who are diagnosed with DCIS are bombarded. They have been bombarded probably for the last 30 years about having to, the importance of mammography. Mammograms save lives. If you're a good friend, you're going to recommend that your friend gets a mammogram. So there's a lot of steam behind women wanting to get mammograms, feeling that it's the right thing. And then when a diagnosis occurs, and carcinoma is part of the name of the diagnosis, this whole media campaign has really hardwired in women that they need to act immediately. They are able to save their lives if they act in an aggressive way. And that is the whole huge burden of media attention that's been brought to that. There is, however, an emerging interest on the part of the media about what happens if we do nothing. And a few years back, there was quite a kerfuffle when we opened the COMET study, because there was a fair amount of controversy over whether the study would hurt patients. And I really was gratified to see that there was a little bit of traction around trying to understand whether we could better personalize the invasive treatments that we offer to patients. And of course, there are very well-researched books, including from authors in this audience, that help to at least provide some evidence that helps to combat some of the constant media barrage that women are facing, and leading to their fear and anxiety and reluctance, actually, to follow a surveillance sort of strategy. So clearly, informed decision-making is important here. I think I've spent most of the time talking about some of our efforts to develop some high-quality evidence to share with our colleagues and our patients. But at the end of the day, there are going to be risks and benefits of all the decisions that we make around this. And so I think shared decision-making, as we've been talking about in this conference, is really going to be fundamental to how we shift the field. We haven't talked much about the role of technology and the internet, but clearly there are some roles for interactive patient-facing tools. I've been fortunate to work on a couple of these. There are a few that are available online, and I think we need to do more of this so that patients can educate themselves on different treatment options for their disease. And then we have a website. I would love it if you could just check it out, cometstudy.org, that explains the diagnosis, what its clinical implications are, and possibly offers a path forward for the future. So in summary, DCIS is an unintended consequence of breast cancer screening. The excellent outcomes for DCIS, as well as the heterogeneity in outcomes for DCIS, presents an opportunity for reducing overtreatment in a significant proportion of women who are diagnosed with this disease. We made this problem with screening. I think we can address it with science. And to that end, there are trials in progress internationally to determine whether the lowest risk DCIS could be effectively and safely managed without surgery. I think this development of some prognostic markers will allow for more confidence in this type of risk assessment. But clearly, the path forward requires very deep and sustained engagement from patients, health systems, professional organizations, and the public and the media. So with that, I'd like to acknowledge all the people, a huge number of people I've been fortunate to work with on this very difficult problem. Acknowledgements for all of my collaborators. But as I show this slide, I just want to tell you, I was struck by how really difficult and expensive it is to go down this path. Just as it is very expensive to do mammograms, combating some a guideline concordant treatment that was actually, the guidelines were established way before we understood anything about the disease. It's expensive, it's time consuming, but I have to say there are lots of people who are interested in this problem, fortunately, and this is one potential path forward. So I'll stop there and thank you very much for your attention.
Great, thank you so much. Okay, so our next speaker is Professor Jim Dickinson. He's a professor of family medicine here at the University of Calgary, and his teaching and research interests are in prevention, especially screening for disease, mainly in cancer. And he runs the Alberta Community Influenza Surveillance Program, and he was a founding member of the reformed Canadian Task Force on Preventive Healthcare. So please welcome Professor Jim Dickinson.
Good morning. Good to see you all here. Thank you. My conflicts of interest are minimal. Nobody's wanting to bribe me to do anything, unfortunately. I'm a member of the Alberta Breast and Cervical Cancer Screening Program Committee. I'm going to talk about family medicine, general practice, primary care, whatever it's called, where you are, its role in healthcare and how that affects overdiagnosis of our patients. I'm going to use an example from policies on cervical screening in Canada, talking a little bit about the Canadian Task Force, looking at some errors in medical thinking and what needs to change. Primary care is a much more complex part of medicine than many people understand, particularly those in specialty care. They think we just look after their problem, but no, we look after a whole lot of other things. In the context that patients are living, which adds further complexities. An Australian study showed that 185 different diagnoses account for about 85% of the work. But if you go beyond that, you're talking thousands of diagnoses over the course of a year, compared to most specialists who are working with 5 to 10, maybe 20 different diagnoses. So it's a very different setting. The goal of good primary care is that we should be able to manage over 95% of the problems that come in the door and only refer a small proportion onwards. So we're often judged by that small proportion rather than what we do in the 95%. And it's getting more difficult. There's increasing complexity in what we're expected to do. We often have to deal with several topics at once. We now have a lot more older patients who survived more illnesses, which may affect their current problem. And there's lots of new diagnoses and new medications and new tests and so on. Why does it matter, particularly for the public? Well, it's the starting line for lots of adventures in healthcare. Investigation, screening or treatment. There's an escalator. Once we put people on that escalator, they get it who knows where. But we need time to think and discuss before people step on. And it's particularly difficult because it's a low probability setting. We have a role as a filter or discriminant because we've got early disease. And much of that early disease, leave it alone, it'll get better, is the mantra that we have to teach our trainees. But which ones have something sinister where we've got to do something? That's the tricky bit. At what probability do we refer? And that's all in a setting where often both patient is anxious about something and we get anxious about things too. We need to treat our anxiety. And it's a real problem for our trainees because they come out of teaching hospitals where they're taught, no, you deal with anxiety by going for certainty. And they have to unlearn that. It's a place where there's low gratitude. I worked in Hong Kong and learned about Sun Tzu. You can put it another way. Our job is to keep healthcare boring. You know, trainees are very excited with the acute asthma or the heart attack or the broken bone. But, you know, the patient isn't so excited. They'd much prefer not to be in that exciting situation. And that's our job, is to try and keep it that way. But it's difficult because of what's been called the McDonaldization, that resources are limited. We're paid at relatively low rates and have to, in private practice, particularly in Canada and Britain and so on, you have to really push people through very fast. And then it's very difficult to deal with the complexity. And it's a bad habit sometimes to use a signed piece of paper as a way of finishing the consultation and bring them back later so you can have another think, or even referring when not needed. And so for screening and prevention, where we need to discuss nuance and the balance of benefits and harm, it's really extremely difficult. We're generally users of information. The ordinary workforce uses information rather than creating it. And so we rely on external sources to tell us what's going on. Often when the patients come in, the first time we hear about new ideas is when the patients come in with something out of the press, and then we've got to quickly work out what's going on. But we're also users of guidelines. And these are the phrases I hear our trainees using all the time. And that's a problem very often. They don't understand the nuance. There's been an explosion of guidelines, which are very hard to deal with, often run by commercial or special interests. And other people have talked about these issues in this meeting. And they're not easily available. Here's an example, which I know Tim Wilt will be talking about more on another occasion. The Canadian Task Force put out these guidelines in 2017, saying basically don't screen for hepatitis C. And a year later, in the CMAJ, funnily enough, we see the Canadian Association for the Study of the Liver, which is a grassroots, not a grassroots, an AstroTurf organisation, put out another guideline saying, yes, do screen. So I won't go into the details of that because I think Tim is going to. Change, improvement can happen, and I'm going to give an example of cervical screening. Now, the policy in this country, well, it wasn't really a policy initially. People just screened annually. And various reports, because Canada did a lot of the early research in cervical screening, reports said 3 yearly is enough. But they were sabotaged immediately after that 1991 report. In the same edition of CMAJ, a letter was published saying this. Basically what these are the presidents, the influential presidents of the gynecological societies, and in the second paragraph basically is saying, because we aren't getting everybody, we should therefore overscreen those who attend. One of my colleagues in Australia, Anne Kavanagh, showed just how much over-screening causes colposcopy investigation, particularly in young women. That left-hand column is really quite striking. The number of investigations per valued outcome. So I returned to Canada in 2002, and what bills itself as the premier women's hospital in the country had this on its website. Now, there's lots of problems with this statement. I'm sure you'll all agree. So basically, Canadian doctors were running this sort of process, which have changed the policies. I got onto the committee here in Alberta because healthcare is run provincially, so the screening policies are provincial. And I advocated to try the European policies. You know, start at age 25 or 30, 3-year interval. That wasn't going to fly. We got it moved up to 21 at least into a 3-year interval. And since then, the dominoes have slowly fallen, though they still haven't all fallen across the country. So now we have make an appointment with us today. Sorry, the formatting of this didn't come out very well. So the Canadian Task Force was reformed in 2009. We gradually got together in our methods. It's difficult, particularly the evidence is never as good as you would like it to be. And we're always working on a decision balance about what's the benefits versus what's the harms. And our recommendations on cervical screening, we looked at the balance of benefits and harm, and we used the grade scale. And the thing about the grade scale is it's a 4-point scale, which stops you from sitting on the fence. You've got to be either for or against something. You can't say, well. So we came out with this set of recommendations. Strongly against under the age of 20, but then gradually the evidence changing so that by the age of 30, there's good evidence in favour of screening. So somewhere in the middle there, you start doing it. And the task force has since changed its grading from weak against, because people didn't understand that, now calling conditional, implying discussion. And the public response to that was there was an outcry that obviously we were changing the policies of the government, changing policy to save money. And there were all sorts of stories of women who had pap tests and were saved from cancer. Mostly they'd had maybe CIN3 and had a treatment. And the gynecologists were still very slow to agree. Now, they're very influential in the provincial policies because they're the experts. And even now, choosing wisely still only says don't do it under the age of 21. And physicians, when they read the policy, read it as start at age 25. They missed the nuance. So now we get the invitation card at age 25. How's it worked? Well, my PhD student, Amber Sayed, looked at pap testing here in Calgary. And what we see on the vertical axis is the proportion of each age group who'd had a pap test in that given year. And you can see it starts from very young. At the bottom is, there were some pap tests done in girls aged between 10 and 14, 15, 16, 17. And you can see the Alberta guideline did have an effect. Actually, it was helped by the pathologists, because when they got some of the really young ones, they would actually phone the doctors and say, do you really want me to process this pap test in this young girl? So they played a role. But you can see there was a substantial drop, depending on age. But you can see that once you got over 21, the group stayed similar. Remember that if you were testing every 3 years, then it should be 33%. And most of the age groups are above that. Bearing in mind there's still a proportion of the population that don't get pap tests at all, then that means that those who are getting it, quite a lot are getting it far more often. What were the outcomes? People said, oh, if you stop doing this, terrible things will happen. Well, the abnormal test numbers dropped in parallel with the reduction. And particularly the peak was in the young 20s, and it's lower with age, as we know. The biopsy rates dropped accordingly, but there was absolutely no increase in invasive cancer diagnoses, which is hard to detect, of course, because there's so few, particularly in these women under the age of 30. Of course, things are going to change further. Now they're seen as changing with HPV vaccine and HPV tests, but the greatest problem still remains that we're over-testing one group, and there's a whole group that aren't getting testing at all, and they're the ones that end up getting the cancer. So the reflections on that are that human factors way overcome the science and the evidence. And there's a lot of studies summarised by Tammy Hoffman and Christelle Marr, shout outs to them, the late Christelle Marr sadly, showing we overestimate the benefits and underestimate the harms. The other problem, I think, is that doctors have a huge difficulty, all humans have a huge difficulty jumping between probability and binary, because as doctors we act. Action is a binary thing. You do it or you don't do it. I have a lot of problems with the philosophy of Star Wars and so on, but particularly with this, because it doesn't deal with nuance. The fallacy of the cut point, where we have a measurement that as the measurement increases, the risk of something increases, whether it's diabetes or lots of other things. You do a cut point, and there's healthy and the sick. Of course, the numbers are more like this. So most people are only just over the cut point. But what we do is we have black and white thinking. We go to black box and say, these people are diabetic, or these people have bad pap tests, or mammograms, or whatever. We omit the nuance that underneath that black box, there's actually different groups in there. It gets even worse if we change the threshold for disease. We move the threshold downwards, and so we get an even bigger black box. DCIS is an example of that, where once you're in the black box, hey, anything goes. So there's lots of errors in thinking that we, particularly in primary care, have to deal with. That specialists who see the end stage of disease think they're experts on screening, but they don't actually have any experience of it. Because we're saving lives, anything is worthwhile. If a little bit is good, more must be better, and that certainly happened with the pap testing. The idea that all early disease progresses to end stage without action, and that we can prevent all of it. And if not, then it must be someone else's fault, and it's often the primary care physician whose fault it is. We've got to recognise that across the spectrum of disease, this is merely another way of the graph that Shelley showed, saying that, well, screening is helpful for a small group of people. And for different diseases, different problems, the proportions differ. And we need to think about, in any given situation, where are we on this? Can our critical thinking overcome the various biases? I mean, one of the problems is, as humans, we have innate hope. We want to do things. We think that'll be a good thing to do. We talked about specialty bias. Financial bias, of course, in this country, as in many others, we overpay procedures, not for discussion and behaviour change. There's industry influence, and the industry influence comes right in our doors, and the media perceptions. I think the problem starts with medical education. The content load is now overwhelming. I mean, I'm about to get to my 50th anniversary of graduation, and things have changed an awful lot in that time. And the content has just got a whole lot more. I think more and more the students are learning the stories of science, not the process. They learn how to think scientifically. Because medicine is taught as algorithms with binary decisions, not probabilities. They lose sight of the probabilities. It's very difficult to unlearn the simplistic approaches once people have learned them, and that's how medical schools mostly work now. It's more of a trade school than a scientific institution, I'm afraid, most medical schools. Certainly in North America, I can't talk of Europe. The people at the front line are busy. Few read medical journals, certainly not critically. They read the basic journals, and so much of the research you guys do goes into research journals, which are never read by the front line. You've got to find ways of getting it into what people actually consume. CME programs, well attended, large numbers of people in the audience, but when you compare that to the great unwashed out there, no, not well attended. And the science of medical education is still pretty limited, except a lot of it is known by the drug companies, but they're not telling. But it does cost them a lot. So good medical education and change actually costs a huge amount. And yet primary care is grossly under-resourced in most countries of the world. We need more time for patient visits so we can do what we're asked. There needs to be more healthcare system investment to support the front line. Canada has a particular problem that the 2-year program of training for family medicine is the shortest in the civilized world. Because if we had more skills, if our trainees had more skills, there'd be less need for referrals and the whole system would work better. We need to put more investment into unbiased CME rather than the drug companies coming to our doors. And there are some tremendous things, and a shout out to Tools for Practice here in Alberta, the Therapeutics Initiative in BC, RX Files is a tremendous drug information resource, one of the best things that comes out of Saskatchewan. They are drug representatives, but for good purpose rather than bad. They go to every doctor's office, and that's great to see, but we need to do a lot more of that. So fundamentally, I think we have a major problem with primary care being the front end of medicine. The decisions we make lead up the escalator. We need to get better decisions in the front line. And I think overall, when we look at medicine around the world, we need much more academic input for family medicine, training of our teachers in critical appraisal rather than just how to do what they did before. We need more research funds that are focused on what we do in the front line and more on how we can do patient care quality. And ultimately, we can only do that if family physicians, frontline doctors are getting equitable income. Yet, in general, in most countries of the world, they get the lowest income of all the medical specialties, which is a problem. So we have to reallocate funds if we're going to get anywhere and improve things. Thank you.
Okay. Actually, so our next speaker is going to do his presentation remotely. Alan Francis is professor and chair emeritus of the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. He served as the chair of the task force for the 4th Diagnostic and Statistical Manual, the DSM-4, but subsequently became critical of the DSM for overbroad expansion of psychiatric diseases and medicalization of human behavior, leading, among other things, to writing this magnificent book whose title, I think, really summarizes in 2 words why so many of us are involved in preventing overdiagnosis. And I sometimes think we should change the name of this conference to the title of his book, which is Saving Normal. So thank you, Alan, for speaking.
Well, thank you, Steve, and I just wish I could be with you all today because the conference has gotten off to a wonderful start. And what I'll be saying, I think, will to some degree be summarizing what previous speakers have so eloquently delivered to you. And special thanks to Steve. We met many years ago when he gave a regular conference on educating journalists to provide the real truth, not the press release truth of scientific publications and drug company quotes advances. And I think he did more than anyone else in the field to make real the fact that the public is terribly misinformed about medical care, that medical care is over-promised and under-delivered, and that we all have a responsibility to try to bring reality to a field that currently reeks with misinformation. So in terms of medicalizing normality, I think you're all familiar with the fact that most diseases don't have very clear cutoffs. That's certainly true in mental health, that there's no clear boundary between mental health and mental illness. And it's true for really many of the medical illnesses that we have to treat. And experts can't be trusted in establishing the boundaries. You just heard an explanation why, that experts have their pet diagnoses. I've been working with experts now for 40 odd years, and I've known many thousands of them. And I've never had an expert come up to me and say, you know, my disease is being overdiagnosed. I'm really worried about mislabeling and the harms that are caused by it. Maybe we should narrow the definition of my disorder. Experts in any area have a very distorted view of clinical practice. They work in research clinics with very highly selected patients, very elaborate protocols to get into the study. And they have no idea at all how that translates to everyday primary care, where patients have to be seen, you know, every 10 or 15 minutes, and they're unselected and much more likely to be at the boundary between health and illness. So experts are seeing the sickest patients, and they make assumptions based on their experience with highly specialized staff dealing with the very sickest patients. And the guidelines they draw up are completely inappropriate very often to the average clinical practice in primary care. And even the well-meaning ones, even the experts who don't have financial conflicts of interest, and most experts are well-meaning. There are a few that I think are heavily influenced by industry and really are a disaster to the field, but most experts are well-meaning. But even if they're well-meaning, they inevitably and undoubtedly have intellectual and emotional conflicts of interest because they love their pet diagnosis. They work with it all the time. They see it in a hypertrophied light and don't realize that in a public health context, their disorder may not be nearly as important to the public as it is to them. They don't realize that the average doctor has too little time to be making good distinctions between health and illness, this very populist boundary between health and illness. And they assume that what they can do in their research clinic, spending hours of evaluation time, will in some way translate to average clinical practice. It never does. I think another real problem is that patients have been schooled to expect miracle cures. The press is constantly filled with promises that doctors can't deliver, and patients expect something out of the visit. And unless the doctor writes a prescription or does something to give them something, they often leave dissatisfied. Doctors are more and more worried about their ratings. And the easiest way to get a patient out of the office quickly is to write a prescription, which implies that they have a diagnosis, a need for the diagnosis, a need for the medication. And it's been demonstrated over and over again that there's no sort of limit to the need for medical care, that the more medical services you supply, the more will be demanded, that the number of doctors in the area does not necessarily correlate with good medical care, because past a certain point, those doctors will be prescribing too many tests and too many treatments, and there could be too many cooks spoiling the broth. A terrible problem these days is patients having multiple specialists, all of whom doing their own little particular thing without any attention to the needs of the whole patient, with the result that there's an enormous amount of polypharmacy, especially as people get older and they don't clear medicine so well, and they have more and more doctors that they're seeing. And this, very often the symptoms they present with are due to the medication rather than to underlying disease. In elderly patients, the first thing you should always think about with any new symptom, medical or mental, is this a medication side effect, the result of interactions between among all the medicines the patient's taking. And there's a tremendous tendency in our field to hide medical mistakes. The recent interest in this, but by and large, we're the opposite of the airline industry, where every problem leads to a very complex investigation, a grounding of the planes, an effort to figure out what went wrong, and a feeling of responsibility to have it not repeat. Transparency is very important in the airline industry and much neglected in medical settings where mistakes tend to be hidden. Everyone's worried about malpractice, being blamed. And as a result, we don't learn from our mistakes, and we keep making them. Next slide. Next slide, please. You've heard about screening. Screening never makes sense in the general population in psychiatry, and is, I think, given too much credibility also in the rest of medicine for reasons you heard about. That it's inevitable when you do screening, there's never going to be a clear-cut marker of health versus illness. And particularly when you're dealing with the general population, that boundary is especially fuzzy and especially populated. The bell curve peaks at the boundary between health and illness, very often for many disorders. So as a result, there will always be a high false positive rate. The specificity of screening is usually set low in order to increase the sensitivity. But what that means is that you're inevitably going to be identifying people who shouldn't be identified with any screening procedure. And this leads routinely, you're all familiar with this, you've just heard it leads routinely to excessive treatment, to stigma, to reduced expectations, and to overloading the medical system. And one of the terrible things in mental health is that we so much worry about the mental health of people who are basically worried well, that we completely neglect the needs of the severely ill. And so the United States spends an enormous amount of money on psychiatric drugs, but we often give them to the people who least need them. The drug company market is biggest for the people who least need the medications. The population of people with severe mental illness is maybe about 5% of the population, but 20% of the population is taking a psychiatric drug. Drug companies aren't that interested in the 5%, even though those are the people, the severely ill, who need medication. They're very interested in getting towards the 20%, because those people often will get better even without medication. And once a person starts, usually if a patient comes to a primary care doctor, it's at the worst day of their life. Whatever happens in the next 2 weeks, they're going to feel better. But if they get a prescription that first day, they will misattribute the benefit to the medicine. Very often people will stay on medicine for years, sometimes a lifetime, when really they didn't need it. And it was really, the placebo response rate is enormously high for people with mild illness. The placebo response rate is very, very low for people with severe illness. But as a result of the fact that people, when they start a medicine and feel better, don't understand the regression to the mean or placebo response, they will almost uniformly credit the medication for the change in the benefit and will stay on it for magical reasons, accumulating side effects when really there's no benefit. So screening should, I think, be restricted to, at least in psychiatry and probably in many areas in medicine, screening should be restricted to high-risk groups where it can be very important, very effective. In psychiatry, we should be doing screening of mothers postpartum, because there's a fairly high percentage of those mothers who will have a postpartum depression or psychosis. They can be readily identified and distinguished from average postpartum blues, and there's tremendously high risk to both the mother and child. Makes perfect sense to be screening for depression in that environment. There are many places where high-risk groups will benefit from screening, but general screening of the total population almost always turns out to be a disaster in mental health, and I think in most of medicine as well. Next slide as well. Now, how about setting disease thresholds? You just heard something about that. Disease thresholds are almost always arbitrary, and the people who do the setting usually are highly biased, have their own subjective views based on seeing the very sickest patients and not realizing how the thresholds they establish will translate to general practice. Tiny differences in where the thresholds are established can have enormous influence on rates. For something as common as depression or anxiety or hypertension or diabetes or any number of medical conditions, a very small change in where you set the threshold, because that's the most populated part of the curve, that you can get dramatic changes in the number of patients. When the cardiologist made the mistake of changing the blood pressure thresholds for hypertension, tens of millions of people suddenly had hypertension who previously were considered normal. And you can never trust the medical association to set the boundaries for its condition. It's like having foxes guard hen houses. The American Psychiatric Association should not be in charge of setting thresholds for psychiatric disorder. The cardiologist should not be in charge of setting thresholds for hypertension. The endocrine specialist should not be in charge of setting thresholds for diabetes. It's very important to have the specialty groups involved. They have invaluable knowledge. You could not do a guideline without them. On the other hand, they're getting to call the shots means that they will inevitably set the thresholds such that the many more people will be mislabeled. In the effort never to miss a patient, they will capture dozens of patients who shouldn't get the label. And the harms of over-treating generally far outweigh the harms of missing some patients. You'll never have perfect sensitivity and specificity. It's always a trade-off. But I think that the balance has swung way over in the direction of excessive sensitivity and very deficient specificity. And partly that's because the medical associations have been, the specialist groups have been so powerful in setting the guidelines for their disorders. And as I said before, they never will say, I'm worried about overdiagnosing. They will always say, I'm worried about the missed patient. So I think guideline development needs to be in the hands of people who are experts in guideline development, getting consultation from the groups involved, and those groups should be very widely defined. I much more trust guidelines that are influenced by primary care doctors than guidelines that would be set by a professional association. I worked as part of a group that set rules for guideline development. It shouldn't be that each association goes out and invents the wheel on how to do a guideline. There should be standardized methodological procedures so that the guidelines are following a format that will reduce many of the risks that we've been discussing. Next slide. Next slide, please. Now, I don't want to belabor the obvious, but I guess I really do, because we have to realize that although every once in a while drug companies do a good thing, and certainly developing the COVID vaccine is an excellent example of that, although the way it's been commercialized and the profit-driven effort, even in this catastrophic moment of the drug companies, is deplorable. The drug companies are not nice people. They're not oriented to patient care. They're geared tremendously toward shareholder value and even more to the stock options of the executives of the company. Their influence is absolutely pervasive. I think the latest figure is that they spend something, the pharmaceutical industry spends something like $400 million a year in the US on lobbying. The drug industry by itself spends more on lobbying than the oil industry, the energy industry, and the insurance industry. Now, energy and insurance are not slouches at lobbying in Washington, but if you take their combined lobbying power, it's less than the pharmaceutical industry all by itself. As a result, they've just bought the politicians. The reason why we can't negotiate price in the way that you can in Canada and the rest of the world negotiates price, the US government is the biggest purchaser of drugs in the entire world, but it's constantly ripped off because the rules have established that the drug industry gets to set its own prices. The new cancer treatments that come out are now costing hundreds of thousands of dollars because there's no pushback, because the politicians now work essentially for the drug companies. They don't work for the consumer. They don't work for the general public. They don't work for the voters. They are essentially in the pockets of the drug industry, which is spending an enormous amount of money in what's essentially bribes. And that the bribes affect how they vote on things like negotiated prices. So everyone talks about, we're going to negotiate lower drug prices during the campaign. It never happens after the election because of the undue evil political influence that comes from big money. Big money has a gravitational effect and attracts big power. And the politicians in Washington, at least, are completely in the pockets of big pharma. One result of this is that we allow direct-to-consumer advertising, which I understand crosses the border very comfortably to Canada. And whenever there's a new and potentially profitable product, there'll be constant ads on TV selling the illness, not the particular drug, but selling the illness in the hopes that overdiagnosis will lead to overtreatment. Only the US and New Zealand allow these direct-to-consumer advertisements, and the entire reason for this is the fact that the politicians are in the pockets of the drug company. They've also bought the patient advocacy groups, as you've just heard. It's absolutely absurd that groups interested in Alzheimer's disease would rally and lobby so actively for a proposed Alzheimer's drug that even the experts realize is completely useless and potentially quite harmful. The patient advocacy groups are now just another marketing arm of the drug companies. They were, at the time they were established, a tremendous hope for the future, and they've turned out instead to be much more harmful for the most part than helpful, because they get so much of their budgetary support from the drug companies. The FDA is an absolute disaster in the United States, completely untrustworthy. And this is not surprising because 75% of its budget comes from industry. So the powerful force of controlling the budget is felt by everyone who works at the FDA and influences the decisions that are made. There's also a revolving door that everyone from the director on down is likely to have come from the drug industry or be going to it, or more likely in a revolving door from the drug industry to the FDA, back to the drug industry. And some people manage to go through this process a number of times during their career. The FDA is essentially the fox guarding the henhouse. Again, it's a marketing arm of the drug companies. It's no longer a regulator of the drug companies. There's a complete regulatory capture. And as we learned with the OxyContin horrors, that not only was the FDA purchased by the drug company, so was the DEA. An action that could have taken 15 years ago that would have saved hundreds of thousands of lives, not taken because at the highest levels of the DEA, there was tremendous manipulation from drug company lobbyists. Very important, by the way, people like Rudy Giuliani, one of the most evil influences in US life in the last 30 years, was actively influencing the DEA and the FDA to soften penalties on Purdue Pharma in a way that allowed the OxyContin pandemic to continue 15 years longer than it had to. The drug companies are mostly interested in drugs that are almost exactly the same as the drugs they have now, but can extend patent protection. The amount of innovation in the drug companies it's appreciable. I mean, we have this wonderful COVID vaccine. There's some promising cancer treatments. But by and large, the ratio of useful innovation to let's just do this tiny tweak so we can make a lot more money, that's a very small ratio. The drug companies say that the reason that they need to have drugs being priced at such ridiculously, obscenely high levels in the US is because this supports research. That's a complete cover, a shroud for the fact that most of the profit goes to the shareholders and the executives, that the research effort for drug companies is mostly infomercial type research. I would never trust a study that's done by a drug company because so often the results are geared toward the marketing arm of the drug company rather than towards patients. Drug companies really have an evil disregard for patient welfare, for the economy, for the good of the country. They're very selfish corporate entities that really have only their own survival and enrichment at heart. And we can't trust the science, the quote science that they produce. Every once in a while, there'll be a wonderful breakthrough, but that's a cover for creating an industry that's tremendously bloated with profit and tremendously underperforming in terms of scientific advance. Next slide, please. Now the media, and this is where Steve was so important. Unfortunately, the conferences he gave are no longer being funded by NIH, but at its worst, every morning I read things that just turn my stomach. At its worst, the health reporting that occurs in all of, even the good papers, even the Times and Washington Post, even the very best of newspapers, and even the very best of scientific journals, a lot of the reporting is very misleading. The emphasis is always on the benefits of this new drug and its potential ways of curing human suffering, almost never on the risks of the new drug, and very often almost no critical methodological thinking about, does this study really prove what the makers are saying it proves? And you can't even trust the very best people in our field. That so many of the best scientists at universities have one foot in industry. Everyone is trying to start a company the minute they have a discovery that starts in an academic environment. There's tremendous pressure at the university level and tremendous financial incentive at the individual level to get a company out of that, or to interest a company in licensing it, that the results are always overpromised. Whatever the results may have been, it will sound like this is going to be a tremendous boon to humanity, and that within a few years, we will have cured a disease that's been bedeviling mankind for many generations.
Sorry, Alan. Sorry, this is
I'm
Stephen.
about to finish.
Alan?
Yes.
Oh, you can't hear me? Oh. Sorry, can you hear me, Alan?
Yes, I can.
Yeah. So we have to wrap up.
I'm winding up.
Okay, thank you.
Never believe the claims of new diagnostic tests and new treatments, because they're always going to be influenced by the particular conflicts of interest of the people making them. Next slide. This is a David and Goliath battle, and we're David. And we're David without many pebbles. That the industries, the healthcare industry, the $4 trillion that are being spent on hospitals and drug companies, that they have tremendous power politically, tremendous misinformation outlets, and we have this small conference. The only hope over the years is that might can somehow be defeated by right. And I think that the best conferences I've ever been at have been the overdiagnosis conferences. Started attending them many, many years ago. And I'm really sorry I had to miss this one because of COVID. But I think what you're doing is a virtuous effort to defeat what's actually has become a very malign industry. And our only hope is that by spreading the word as much as possible, people begin to catch on, be wiser, be more cautious. Thanks very much, and enjoy the rest of your conference.
Okay, thank you, Alan. So now we're going to have time for some Q&A. So Shelley and Jim, if you can go over there, and Alan, you'll be joining us. Okay, good. Okay, and what we'll do is I wanted to just start and give the panel an opportunity if they had any questions for each other, and then we'll go to the audience, and Arnav is going to help. He's monitoring the people who are on remotely. So panel members, if you got any questions for each other? No? Okay. Shelley, did you want to ask a question?
I wish Alan would stop being so nuanced and tell us what he's really thinking.
Okay. Okay. And Alan, have you got a question for the other panel members, or should we go to the audience?
I think the reason I'm not the slightest bit nuanced about this is I don't think there's much nuance in this area. I think that we're victims, and Canada is much better, but in the U.S. we're victims of an overwhelming industrial overreach, and it's not getting better.
Yeah. Okay, so there are
I fear
questions.
that Canada is only a little bit better. We're still too close to the elephant, as Pierre Trudeau talked about, and too much flows over the border too easily.
Are you saying that we're fat? Is that you just call this? Okay, questions.
I would actually like to start off with a comment and invite Renee Pellerin to make a few comments about how we on the provider side can partner better with journalists and the media to try to amplify this message, that we're hearing about at this meeting. I really appreciate your thoughts. So Renee is the author of one of the books I mentioned in my talk.
Yes, you kind of put me on the spot, even though you gave me a bit of a warning a few minutes ago. But it's such a complicated situation. And when I tried to unravel that situation in my book, I just got deeper and deeper into how complicated and in many ways hopeless it is to get the truth out to the public. And as a senior journalist for the Canadian Broadcasting Corporation for many, many years, it's very difficult for journalists who have a job that every day requires a new assignment, and they are covering everything from all the soup and all the nuts, and are not specialists in the way that the experts in healthcare are specialists. And it's very difficult for them to navigate the crappy information that they get from the pharmaceutical industry, from the charities who are raising funds and trying to scare people to death about cancer, and navigate the information that comes from specialty journals. It's an almost impossible task. And somebody made the point in a session yesterday, and I think it really behooves all of you who are scientists to work with journalists. Pay attention when you get a call. Explain. I don't think that we can train all of the journalists to be specialty health journalists and can cover breast cancer and diabetes and lung cancer and social determinants of health all at the same time. I hope that answers your question.
Thank you.
Barry?
So first, thanks to all three speakers for really three outstanding talks. I want to direct a question to Shelley Huang, who gave a great talk. For very good reason, you focused on identification of, I'll refer to it as overdiagnosis, within ductal carcinoma in situ, non-invasive lesions. And as you know, the urologists have been focusing on invasive disease for identification of overdiagnosis and ways to mitigate overdiagnosis. US national trends show that in association with mammography screening, there's been a large increase in ductal carcinoma in situ, but not just ductal carcinoma in situ, but also early stages of invasive disease. And there's been very little reduction in locally advanced invasive disease, and virtually none in metastatic disease. So I think that produces mounting evidence that there's a pretty strong element of overdiagnosis even amongst the invasive diseases. So my question is, do you envision research strategies that can extend beyond DCIS into invasive disease? What are the current ongoing efforts, and how do you think they should be expanded, and if so, how?
So Barry, a lot of the things that you've been talking about for many decades have helped to inform the thinking of many people, including myself. And I think you're absolutely right in that, breast cancer in particular, and the treatment that patients have to undergo for it has been just a very entrenched problem. And I really do think that the messaging that women get through the media is both helpful in terms of increasing awareness, but harmful in terms of making this disease probably the most dreaded disease that women face. So unlike in prostate cancer, where there's, I believe, a lot less hype and advocacy around it, I think there are opportunities to use evidence to sway what the decisions that patients and providers make. And I think it's been really gratifying to see that the prospective randomized trials looking at active surveillance in early stage prostate cancer have actually started to be implemented in a pretty major way that affects so many men who have this disease. You're absolutely right that there's overdiagnosis of invasive cancer as well. But given how difficult it's been to move the dial on DCIS, I think you have to start picking your battles. And I chose to focus on that. But our recent paper shows that a higher proportion of overdiagnosis actually happens in women with invasive cancer. So I think there's still a lot of work to be done. And we started with what we perceived as the low-hanging fruit, but even that, I have to say, for all the forces that we've talked about today, it's been really hard dialing that back. I look forward to the day when we're going to be able to make some inroads into invasive cancer as well, because of course, these women are getting chemotherapy in many cases in addition to the surgical treatments. I think the development of biomarkers can help us to determine which women are at lowest risk for developing metastatic disease. So I think that is, although driven by industry, it has had a lot of beneficial effects in reducing the escalation of therapy that we saw for most of the last half of, the 20th century. So I think there's hope. I just think that the world is probably not ready for us to say that some invasive breast cancers don't need treatment. That would require much more intestinal fortitude than I have.
Just as a comment on that issue, I think one of our big fallacies we have in medicine is the definition of disease. And Alan Francis has talked about how in psychiatry that's a really big issue, and it's very obviously a big issue. But I think in the rest of medicine, we don't ask enough, particularly of pathologists. We tend to believe that if the pathologist says it is this, then it must be so. We need to be, in the few areas I've looked at where I wanted to understand the variation in pathological diagnoses, either there's very little work or it's really worrying. And so I think one of the scientific issues that we need to teach medical students is, we have to question our pathologists as well. And so the boundary between DCIS and early invasive and so on is really
very
difficult.
fuzzy. No, it's very fuzzy and not reproducible. Even among expert breast pathologists where that's all they do, it's very hard to reproduce their read of atypia versus DCIS versus invasive cancer. And I think that should cause all of us concern.
I think also it applies equally well to radiology, and in both professions, the risks for malpractice suits are much higher if you don't mention the possibility of pathology than if you do. So the tendency, if you have to make yes/no decisions, is always to suggest that there may be a pathology there, even if it's a dimensional rating really, and even if you're quite unsure. The tendency is to overdiagnose because you're less likely to be sued.
That's an excellent point.
Okay, next question.
Yeah, hello, my name is Martin Scherer. I'm currently president of the German College of General Practitioners and Family Physicians, and for a long time I have been responsible for the German general practice guidelines. I can fully support your David versus Goliath hypothesis. We have 700 guidelines in Germany, which are potentially applicable for general practice as long as we don't counteract by our own guidelines. We have 30 general practice guidelines, and our guideline committee consists of 70 doctors working voluntarily without any funding. So indeed, it's David versus Goliath, and it doesn't makes my mood better. So as long as we have a psychiatrist among us, can you tell something which puts us out of the depression, or can the panel say something positive about that?
Alan, do you want
I really wish I could be optimistic, but having watched this now, the progress over the last 45, 50 years, things have gotten progressively worse. And I think that the overdiagnosis conferences are like a breath of fresh air. I was never so happy during the year as I was at these conferences, because I was with like-minded people and we were dealing in a serious way with a very serious problem. But the influence of the conferences on the outside world has been really low. I think one of my recommendations for the conferences is to try to have much more of a public relations arm, to bring in as many reporters as possible to try to get this word out. I think I love talking to journalists. It feels like the most important thing I can do in life, because they have an influence we don't have in getting the word out to the public. And I think everything that we can do as Davids to enlist the journalists on our side is crucial, because if you follow the money, there are hundreds of millions of dollars being spent every year to promote overdiagnosis. And the budget to reduce overdiagnosis is probably in the low millions.
Okay, next.
Can I just make a comment on the about the issue of guidelines? It is no longer good enough to say that guideline bodies are voluntary. I think it is real work. It's hard work. If we want to do it, have it done well, then society needs to invest in the people who are writing the guidelines. And if there's, I don't know whether there's any way that this conference can have a resolution or any sort of way of saying that, you know, that model of having good old boys sort of sitting around and being paid by drug companies on the one hand, or having voluntary groups trying to apply the science with no resources, I mean, that definitely is David and Goliath, and that has to be really rethought.
Right. Okay, we have another question here. And we have time really for two quick questions, and then...
Scott Clarenbach, University of Alberta, Canadian Task Force. You know what, a common theme through all of the presentations was incentives and disincentives. It should be while I agree with the harms of pharmaceutical industry, it should be no surprise that they do efforts to maximize returns for shareholders. Similarly, journalists have tight deadlines and they are rewarded by headlines that get a lot of views. And we talked about how specialists want to do everything they can for patients, even if that might lead to harm. How family doctors are penalized for spending more time talking about why you don't need a test, but don't bear the cost of actually ordering a test that might be unnecessary. And I'm just wondering, should we be thinking about this in a way that attempts to align those incentives and disincentives in a way that we think might be better for the public and society, and if there's a way to do that? Just bringing it open, I mean, for example, there could be a change in how drugs are reimbursed. So if you cause harm or you don't have good evidence, that affects the company's bottom line, and that might actually lead to a better alignment of industry incentives versus what we want for publicly funded healthcare.
Yeah. Great. Okay, Adrian, do you want to?
Hi, I'm Adrienne Fu Berman. I direct Farmed Out at Georgetown University Medical Center, and we do research and education on how the pharmaceutical and medical device industry affects prescribing habits. So we have many educational modules, including continuing education for people in the US, but they're available to everyone. We have a whole set of fact sheets on pharmaceutical marketing and sets of references. Please visit farmedout.org. We also will be holding a conference next June on invented diseases. So I wanted to say a word, though, about consumer advocacy groups. It's been wonderful to actually hear people say something about the pharmaceutical industry today, Dr. Dickinson, Dr. Francis, that's been really great. I feel like that's sort of the elephant in the room. A lot of overdiagnosis is because of pharmaceutical and medical device manufacturers. But there are some consumer advocacy groups that really represent consumers. We have a list on the Farmed Out website, at least in North America. We'd love to expand it, of consumer advocacy groups that don't take money from pharma and actually will take pharmaceutical companies to task. I know Suzanne Robati of MedShadow is here. There's the National Women's Health Network. There's Breast Cancer Action, which is my segue to the question. Loved your talk, Dr. Wong. a little depressing because the groups that have not been taking, the women's health groups that have not been taking money have been fighting the diagnosis and the overtreatment of DCIS since either the 1980s or the 1990s. And I was wondering what your opinion was on why are we still overdiagnosing this, and what is the contribution of I don't know, imaging machine manufacturers or pharmaceutical companies to this?
Yeah, so you can imagine that I've been kind of a magnet for advocacy groups that are very interested in de-escalation of treatment, but that is not the main message that women are hearing. I mean, it takes a very rare individual, a thoughtful and, an unaligned person who is able to critically look at the data to be able to start questioning what the media, what her physician, what the radiologist, I mean, it takes a very unique person to have the ability to start questioning that. And I've been very fortunate that I've met a fair number of women who have the courage to start thinking for themselves. But I think that's very unusual because the weight of the pressure on women to worry about breast cancer, to consider doing something other than removing both breasts, I mean, that pressure is profound. It's immense, and it takes a very special individual to fight against that. Even women who've had, breast cancer themselves and they're in advocacy groups, I think a lot of how they justify having gone through all the treatment is to feel that they saved their lives by doing that, because that's how they, after the fact, feel that they can justify the experiences that they've had as part of their treatment. And I think that kind of perpetuates itself when they speak with other advocates.
Great. Well, thank you. So unfortunately, I think we're out of time now. So I just want to thank the speakers for this wonderful session.